Asad, any other tips or tricks you developed over the years to ensure an effective and safe ablation?
Yeah, I think, one of the things is making sure that, you're not around any vital structures. That's, obviously I think that one of the most important things. I always like to tract ablate on the way back. I think that I don't know the data on this, to be honest, but I think that when you're doing that, obviously the risk of seeding goes down exponentially because you're burning everything you came in. But I think also probably just as important is kind of the risk of bleeding. Because again, the last thing you want to do is subject this patient to, an angio. And, I think it's one of those things where it's a small thing, but I think that if you do it, you'll feel a lot better. Patient will also feel a lot better. You can tell them, look, if you're worried about the tumor going anywhere, because that, by the way, that has been a question that has come up in clinic visits is patients are like, oh, if you put this needle into the tumor, are you going to like burst it and it's just going to go everywhere? And I'm like, you know what? It's a valid question. Like I understand the thought process. It doesn't exactly work that way, but I get it. And when I tell them like, look, I'm going to burn on the way out. And, with Imprint, it's like 10 seconds for every centimeter just, coming back. It's pretty easy. And it also gives them a peace of mind as well. In terms of other kind of techniques, one thing I haven't really talked about so much is CT fluoro. I think that especially the place where I was thinking about talking about this, then I forgot, at the dome, like when there's cases like that where it's kind of a tricky position and you I don't want to step out. I don't want to, just put the patient all the way back in, scan comes out. And then, if they're breathing, sometimes I don't have enough blue towels to keep it in its position. And it's like, shoot, like, now it's moved, So sometimes, in certain situations, CT fluoro can be really helpful. So I would say if you have the opportunity to kind of learn that, I would definitely encourage that. Because listen, not every case is going to need it, but there will be some cases that you're like, shoot, I kind of wish I could see this a little bit more in real time. The other kind of, I guess, tip or whatever you want to call it is, especially early on, I would say don't try to be a hero, right? Like, just take the easy ones first. Because, like, everybody wants to show, like, listen, you go on Twitter or X and it's like, oh, everybody's showing their crazy cases and whatever, but nobody's showing their complications, and it's like, okay, you want to be the hero, but like, this is your first few. Don't be a hero. Because it does a few things for you, right? First off, it develops your reputation with patients. Number one, patients are first and foremost. Secondly, it develops your reputation with referrers, right? Because especially if you're new to an institution or new to, just tumor board or whatever, like you're a relatively unknown person. And this happened with me. I'm sure this happened with you, Mike. It happens with everybody, right? Anytime you join a place, they're like, oh, who is this guy Baig? Like, I don't know who he is, But like, the first time you do something, you kind of want to go back to referrers and be like, hey, look, I got this tumor and it looks good. Sometimes I'll even take a picture afterwards and just send it to them and be like, hey, look, we're all visual people, right? Radiology or not, everyone's a visual person and everybody wants to see that. So I say, get an early win. Like you said, Mike, I agree 100%. And then the other thing that'll do is also build your own confidence, right? Because when we've all gone through that. Like the first time you're doing anything as an attending, no matter how good your training is, the first time you do anything as an attending, you're like, shoot, I'm on my own. Like, all right, it's the big time, but like, you're also kind of worried, like, okay, all right, let me just make sure that I do everything in the right way, And then the second time you do it, you're like, okay, all right, I've done this before, and it went well. And like, okay, now I can do another easy one. And then eventually you work your way up to, okay, now I can do things that are a little bit tougher, Sometimes what the referrers will ask is, to biopsy and ablate kind of at the same time. And, one of the things that I personally like doing, and I'm sure you have your own techniques too, Mike, is I try to get them both in at, I don't want to say at the same time, but I won't take the biopsy until I have the ablation probe parallel to the biopsy needle and pretty much like right at the edge of the tumor. So I'll get both the biopsy needle as well as the ablation probe right up to the edge of the tumor before I send out that biopsy tray. And only then will I take the sample. And then right after, I'll just push the ablation probe forward, get it into the tumor, and just get ready to burn. I don't know if you do it the same way.
Dude, I actually get the ablation probe all the way in before I biopsy. It's primarily a concern when I'm doing renal ablations. Usually I have imaging that's pretty classic for renal cell, but they want biopsies. For liver, most of the time I'm doing the ablation. They already have all the tissue that they need. But when I have to do them both, if it's big enough, I get the ablation probe in first, then I put the biopsy needle and get samples. The reason I do this is because early in my career on a renal ablation, I got burned where I tried to do the biopsy first before putting the ablation probe, and then it bled and I couldn't see anything. And liver, that's very unlikely to happen, but still, when feasible, I get the ablation probe in first, then biopsy.
Yeah, exactly. Yeah, and I mean, honestly, I think that's actually a pretty good approach too, because then for sure you're in the tumor with the ablation probe. And I mean, look, these things can happen when you're biopsying, especially anything hypervascular. Like,
I mean, it depends on what the purpose of the biopsy is. If it's important, if they need it for molecular testing, then yeah, we're going to ensure we get that. But if they just need confirmation that it's, an HCC or metastasis, I'm setting my priorities, and my priority is to kill the tumor. So I'll get tissue if I can, but the treatment comes first, and my priority is killing the tumor.
Yeah. And that's one of the beautiful things about microwave, by the way, is like, and especially with Imprint, you have the ability to go for the kill. And like, that's not only satisfying for us, but the outcomes, and I think we talked about this before too, in terms of any cancer versus no cancer, like no cancer post-transplant, like the outcomes are just way better, and you just crank that thing up, get the Imprint to, I think now Imprint has the option of 150 watts as well. So you can really kind of crank it up. And, what's interesting, by the way, is a couple of my colleagues had this thing where if you're worried about cranking it up too high, and this is a technique that we kind of started doing at Columbia. I'm not sure if places are doing it across the country, where we'll actually do like a very low wattage. Like we'll start at like 45 watts and do it for like maybe 30 or 45 seconds. And then we'll go on to our actual burn at like 150 watts. So, sometimes what has happened is, and outside of the liver and the kidney, we've actually had some of these tumors actually kind of rupture. So based on kind of, again, it's not data, but it's kind of anecdotal, but based on when that happened, we thought to ourselves, okay, what could it have possibly have been? Because, the ablation probe was right into the tumor. We kind of did everything as we should, and it just kind of ruptured, right? So then we thought, all right, maybe we're just starting off too hot. Maybe if we just kind of take a little bit heat off of it and start the ablation that way. The liver is interesting though, right? Because the most livers that we do are going to be cirrhotic, fibrotic, like not necessarily like normal livers. I often think to myself, like, okay, do we have to, for lack of better terms, kind of overcook to kind of, get over that? And that's where I think, we were talking about microwave versus RFA. I think just with the additional kind of power that you have with microwave, I think you have a far better chance of kind of killing that tumor compared to like RFA.
Right. And that's the best part. I mean, that's why I love doing liver ablations. It's my favorite liver-directed therapy, because when you're doing a liver ablation, your goal is to get rid of a tumor. And sometimes you can get a complete cure of somebody's cancer. And that's not something we usually get to do every day.
Yeah, exactly. And there are studies that, show that it's curative. It's, equivalent to, surgical resection. So, I mean, again, if I was a patient, I would probably want an ablation as well. Our patients come in, they get their ablation, they go home the same day. There's minimal recovery time. They're back at home at night, and, they're probably going to be sore for a few days, but I think the recovery time, and the data shows it's a lot better for ablation.
Right. It's a much easier recovery.